All right, let's do a quick overview of lung cancer. It is the leading cause of cancer related to deaths worldwide. So this is something that you will encounter in your nursing careers. The problem with lung cancer is that it has a very poor prognosis when it's identified late in a later stage or is an advanced lung cancer. In that instance, treatment often focuses on relieving symptoms or just increasing survival time, so like palliative care rather than cure. It's common, this is a lung cancer, that we often see metastasis through the blood or lymphatic system. And so oftentimes we will see multi-system or organ involvement. And this is what can help lead to kind of that poor prognosis that we see. Big risk factor is going to be exposure to cigarette smoke. So either by smoking, or we'll see it in non-smokers that were exposed to secondhand smoke. So that is a big risk factor that we will want to assess for when we see patients come in. One of the biggest things we can do health promotion wise is encourage, again, no smoking. And then secondary prevention will be focused on early detection for those that are high risk. Some of the warning signs that we'll see are hoarseness, changes in respiratory breathing patterns, a persistent cough that just doesn't go away, hemoptysis or blood streak sputum. They may complain of chest pain, dyspnea, wheezing, weight loss, and again, you might even see some clubbing that you'll see. So always assess for those risk factors that we have talked about and any of those symptoms that we just discussed. Typically, when we see the physical symptoms, it's more late in the disease that we'll see. Breathing can be labored or painful. You might see rapid, shallow breathing patterns, dyspnea, wheezing. You might see that phrematus, those vibrations felt on the chest wall when breathing. And as that tumor enlarges, you might see more alterations of the breathing, breath sounds on auscultation. These patients with advanced stages, because again, how the heart and lungs work together, they can be at risk for fluid around the heart, so that cardiac tamponade. So just be aware that sometimes we'll see some heart issues as well. So we might see dysrhythmias. We might see bone density changes. So we might see those pathological fractures where they have a fracture with no real injury. So bone fractures. And then again, late symptoms are going to be fatigue, weight loss, anorexia with these patients. The poor prognosis has made this be a very anxiety-producing disease. So a lot of times psychosocially, you will see a lot of fear, a lot of anxiety with patients and their family. And then here I've listed some of the most common diagnostic ones. The first 4 are going to be more to actually identify and diagnose lung cancer, where the last 3 are going to be used to help look for any metastasis. So non-surgical treatment will be chemotherapy. You might see gene therapy, immunotherapy, radiation therapy with these patients. And then for surgical management, we can actually see removal of a lobe or even the entire lung. And those patients will often then have a chest tube. I know chest tubes can often seem very kind of confusing, anxiety producing to students. So I tried to go ahead and put up an extra video that is just related to chest tube insertions and maintenance. It's from Deaconess Hospital, but I thought it did a good job at really just kind of demonstrating what it looks like in real life. So if you're unfamiliar, if you didn't really feel like you covered that in fundamentals, I encourage you to go ahead and look at that. Some of these surgical treatments can actually be done through a VATS procedure, which is a video-assisted thoracoscopic surgery. And so these procedures, we're used to, we would see large incisions for the lobotomy. Now we're seeing a more smaller incision. They're minimally invasive procedures. And so I think we'll see those more and more often. And so post-operative care is going to be maintenance of any chest tubes, looking for how our patients tolerate that, looking for excessive drainage with the chest tubes. And so go ahead and take a look at that video and review chest tube care. I've got a couple slides here to show that how the chest tube is going to go into that pleural space to drain any drainage so we can have adequate lung expansion. So it's not going into the lung, it's going right into that pleural space. And then this is kind of just, if you want to pause this, where you can look at the suction control, that you will see some bubbling, gentle. And then the water seal, this is where you'll see that tidling with breathing. And then this is actually where we'll see the drainage that we'll be marking and measuring so that we can see if there's excessive type of drainage. So for those of you that learn best by reading, I wanted to point out this great box in the textbook. This is all covered in the video as well, but it talks about the importance of making sure that the occlusive dressing remains intact to the patient, and just how to assess for any complications with the chest tube. So it'll be the pulse ox, looking for any dyspnea, looking for lung sounds, those types of symptoms. And then this is some important information with just our drainage system. Make sure it remains below chest level. And then again, you should see that gentle bubbling in the water seal. And then you should see the tidling with breathing in that water chamber. Always make sure that the water level is in that water seal chamber. And then you want to minimize clamping or kinks in the tubing, and then make sure that we're documenting the color and characteristics of any drainage. We can, if we get a full collection chamber, we want to switch out. And so we can clamp the tubing and switch out and put a new system on our patient. And here are some good tips on when to notify the healthcare provider that we might have, or the rapid response team, that we may have a problem with our patient. Of course, if we get tube dislodgement, excessive drainage, or if we have low O2 sats, sudden dyspnea, if you see a tracheal deviation. So I thought this was a really good tube. And then this shows a little mini chest drainage system. So we'll see that. So it's portable. And so I will make sure I've got highlights through the rest of this chapter, and let me know if you have any questions in class. One more quick thing with lung cancer. Your textbook does a good job of talking about the interventions that we can do for palliation. So these are our measures for our patients that we may not be able to cure lung cancer, or just complications that may occur while patients are undergoing treatment. So again, oxygen therapy. Radiation therapy can be used to help shrink anything that, like a tumor that's causing obstruction. It can help with reducing difficulty swallowing from those masses or the problems with breathing or hemoptysis. Thoracentesis is when they actually take a large needle or catheter. It's going to be done under sterile technique, place it into that intrapleural space, and drain that fluid. It temporarily then allows that lung expansion, but often that fluid can collect again in that pleural space. But so they may have this procedure repeated, or they can have drains placed into that pleural space to collect the fluid. Anything that we can do to reduce dyspnea, so think about your positions to promote optimal oxygenation. We'll be providing for adequate pain management, and then we may be making referrals to like hospice or palliative care.